Okay, next question. Have you ever seen cases of SSRI-induced gynecomastia?
I haven't personally seen it in my practice, but I know it exists because SSRIs, selective serotonin reuptake inhibitors, antidepressants, are used a lot more these days. And also with antipsychotics, I see or I read about it, but in my practice, I haven't seen too much. As a matter of fact, in my practice, because testosterone is a fantastic antidepressant in and of itself, anyone who comes in on an antidepressant, whether it's an SSRI or Wellbutrin or norepinephrine reuptake inhibitor, I'd say easily 95% of the time will be able to get off of the antidepressants. There are some select cases where people actually have a depressive disorder, and that's usually diagnosed late teens, early 20s. By definition of DSM-4, soon to be DSM-5, the manual for psychiatrists. And that brings up a whole other topic about depression and testosterone versus the antidepressants, which aren't as effective because they're not treating something that they're supposed to treat. But that can be for another day, another question. But yeah, it does exist, and you might try changing to a different SSRI or
start doing tests.
If appropriate, absolutely. But their production of prolactin, because some of the antidepressants affect dopamine. It's probably more technical than anybody wants to hear, but it is possible. But I haven't seen it personally in my practice.
Okay, we got a good one over here. Why is it that with some people, hormone replacement therapy or testosterone will increase their sex drive tremendously, and some people it lowers it, and they don't feel like having sex?
This one's a good one because there's a couple of reasons why libido can be affected. One is the profile of different steroids, testosterone, can be different. And we've all heard of the expression "deca-dick."
I was wondering if you're going to bring that.
Trying to be
candid, yes.
Or phenodick, and that has to do more with erectile dysfunction than libido, absolutely. But of course, the two are connected. As far as libido itself, they can also be affected by the profile of the steroid. But when it comes to just testosterone and what I think more what we're talking about, replacement therapy, the ratio of testosterone to estrogen is a big factor. There have been plenty of studies talking about the ratio of testosterone to estrogen and its effect on libido. I believe, and now I'm going to stretch my memory a little too much, I believe there's a 5-to-1 ratio that's ideal, but again, who decides what's ideal?
Right.
In other words, there's a ratio in which you'll be more receptive to bonding, let's say, as part of the sexual experience, as opposed to the caveman experience, where it's we used to call it the club and drag. Caveman grabs cave woman by the hair, clubs her over the head, drags her into the cave, et cetera, et cetera. That kind of like just I have a primal sex drive, right? But I've talked to people plenty of times where there's not that comparative libido, but there's either a great libido or none
right
here.
Right.
And that definitely is affected by estrogen. So what I try and do is, depending on where they are in terms of follow-up, I'll adjust the dose of anastrozole, either upward or downward, depending on some of the other things, the symptoms and signs that we talk about, and invariably we had an improvement there. Now, just since we're talking about it, the other thing that's probably important to know that may come up in another question, so I'll go ahead and spew here. Erectile dysfunction can be a factor of not only libido, but also nitric oxide production. There's a 30% failure rate with a lot of the PDE5 inhibitors like Cialis, Viagra, Levitra, because there's not any nitric oxide there to block the reabsorption of to begin with. So we can use precursors like arginine, ornithine, and my favorite, citrulline. And I'm sure there's a lot of
it's over-the-counter stuff,
that you can use too, that'll help boost your nitric oxide and therefore at least fix the erectile issue. And I'm sure that most men out there will nod their heads that if the penis is working properly, okay, it definitely improves libido.
Yeah.
Right?
Yep. Oh yeah.
So that might be a first step.
Yeah. Very cool. Very cool. Thank you. Oh, before we started, you were talking about an asteroid, and you'll or what's the other name for it? What's the name for an asteroid?
Arimidex.
Yeah, Arimidex. I'm sorry. What's the normal dosage? What is average normally for a patient without you having to play with it? Is it one milligram a day, or what is it?
My standard hormone replacement therapy involves 1 cc of 200 milligrams per ml of testosterone cypionate.
Yeah.
Testosterone cypionate's ideal because it's the cheapest. It has the longest half-life available in the U.S. We're still waiting for undecanoate to make it over here.
Mm-hmm.
And it's the least painful.
Gotcha.
With that dose, typically I'll recommend 1 milligram of anastrozole every other day to start with.
Every other day, gotcha.
Because I'd rather oversuppress than undersuppress because of what estrogen in excess can do to the male.
Mm-hmm.
And then we do a follow-up roughly at 90 days. Why? Because it takes about 6 weeks for someone who's naive to this before it'll even kick in. You'll start to feel the difference,
right? Or
you'll feel it in a significant way, and then another couple of months for it to for your own production to reach its homeostatic range, and obviously at that point the patient should feel good. Then I want to see the numbers, not really so much for example, the hemoglobin, hematocrit, kidney function, liver function, stuff like that. Those numbers, if they weren't good to begin with, should have improved. If they were good to begin with, they'll stay the same. But really to monitor the estrogen level. So at 90 days, we'll then go back and tweak, if necessary, the amount of anastrozole to get to an optimum range, which tends to, well, first of all, we use estradiol as a surrogate marker typically for total estrogens. And there's an ideal range of about 15 to 20 picograms per milliliter, at which you're still getting what you do need, because we do need some for joint health, cardiovascular health, brain health, but without the excess. And also in that range, we find that you lower the sex hormone binding globulin and therefore raise free testosterone, so you're getting more juice for the squeeze. I don't know if we've talked about this yet, but
nope.
On average, 2% of the total is free and available for use. If we can get that to, let's say, 3%, the less math inclined out there will go, well, big deal, it's a 1% increase. No, that's a 50% increase going from 2% to 3%. That's huge.
Yep.
I mean, that's like, if you get, let's make it easy, if you get to 4%, which I've seen happen many times, that's like the old double the dose and hope for the most, I mean, without having to do that.
That's awesome. Very cool, very cool. And that's why it's so important for people to take blood tests. Sometimes people say, I got to go see a doctor, I got to take blood tests, I hate blood tests. There's a reason, and that's why. It's because you need to know.
Oh, and I tell people when I get started, that's really my pet peeve in all this, because again, testosterone, we have so many studies showing that it's beneficial. We see it in practice all the time. Again, the cat's out of the bag. It's been out of the bag for a long time. So that's not the issue, but the estrogen is, and that's my pet peeve in all of this, is making sure that we keep the estrogen under control so we don't spoil the party, because otherwise, we see nothing but beneficial results from proper use of replacement therapy.
Awesome. Thank you. All right, last question for today, Doc. So at what range of weekly AAS does it put your heart and your colon into, doesn't create damage in the long-term study or anything like that? I think that's the question.
AAS being anabolic androgenic steroids?
Yeah.
Long-term damage to the heart and colon?
Yeah.
Boy, that's a wide open question, because it depends. Really, steroid abuse is more of an issue of chronicity of use rather than dosage. In my experience, you see guys that come in and they've done steroids since they were 20 for, continuously, and they're going to have the fertility issues, they're going to have the chronically low T. Of course, at 40 they're expected to have low T, oftentimes anyway. More so than the guys that cycle on and off and may go to extreme dosages, compared to most, what we see in research, which I realize is limited, but even what I see in clinical practice, and they'll be going on fine in terms of testicular function and all the other functions. As far as direct heart damage, I think he might be referring to the association claimed between coronary artery disease and cholesterol, because all steroids, not testosterone. And when I say all steroids, I mean to always say anabolic steroids, because steroids are all from cholesterol. So I'm not talking about progesterone. Anabolic steroids all will tend to lower your bad cholesterol. We call the bad cholesterol is LDL.
Oh, really?
Sorry, I said that backwards. It will lower your good cholesterol, the HDL, and raise your so-called bad cholesterol, the LDL.
I see.
The problem I have with that claim is that the association between cholesterol and coronary artery disease is tenuous at best, and that's being researched more and more even as we speak. We have a recent study in Britain. It was a meta-study showing there really is an association, and that goes back in time a long way. So I don't believe there's any problem with the heart in terms of coronary artery disease being caused by steroid use. The colon, the only thing I could think of there would be that it would improve your colon, because people who are on anabolic steroids tend to be more muscular, therefore their metabolism's increased, so their transit time is shortened, meaning it moves, feces goes through the colon more quickly, which would lower your chance of problems like diverticulosis and colon cancer. So I would maybe ask him to send back more details, behind the derivation of his question. I'm not necessarily on board with those causing any problems there.
Gotcha. All right, thank you, Doc. That's it for this week. Keep sending your questions, guys. We're gonna keep doing this. Doc is game and willing, so thank you so much for having us. Today we were not going to the gym. It was great to have you at the gym though last week with Hide and Pedro. It was kind of like a good little sidebar in the end. But next time maybe we'll get a tour of the clinic and see where you are and all that stuff. That'll be great.
Well,
thanks, Doc.
For having me.
Thank you.